Welcome and good afternoon to this webinar, which is attempting to cover the future healthcare needs when it comes to medical training. And we're looking at the new curricula for the Group 1 specialties and training in internal medicine. Why are we looking for this event? Well, we will have the new Group 1 specialties curricula developed over the last few years, being launched in August of this year. And the curricula have been put in place because of a need for improved generalist skills that the demand from our population with their multimorbid and aging characteristics mean that we have to have a breadth of generalism available within hospitals. The other aspect is to change the way the curriculum is delivered, looking at high-level outcomes with holistic assessment rather than the need for multiple sign-off and linkages. So this webinar is to acquaint trainees and trainers about what will be changing. We're attempting to bring a four-nation perspective to this, involving talks from curricula leads, SAC chairs, college officers, heads of school, and the JRCPTB managers for curriculum and e-portfolio, in addition to the chair of the Curriculum Development Committee. There will be a chance for questions, and I will be collating the questions that come through, and we will answer that as a group at the end of this webinar, so there will be half an hour where we can be answering questions. At this point, I will hand over to Sue Pound, who is the Vice President of the Edinburgh College, working with Venkat to demonstrate how they feel that their curriculum have been delivered or developed and will be delivered.
Thank you very much, Mike. So Venkat and I have been asked to speak about capabilities in practice, and I'm going to start off by talking a little bit about what they are, and then Venkat is going to talk in a little bit more detail about how those capabilities are assessed. So as Mike has said, there are generic changes to all of our higher specialty curricula in the physicianly specialties, and they will be implemented from August 2022. So that's not too far away. And one of the things that we are doing is changing from, if you like, what came across as being quite a tick box exercise of large numbers of competencies to a smaller number of more holistic capabilities, and it's almost as if we're taking the sort of that next step from what do you know about things to what can you actually put into practice, what can you do, and how can we better assess your performance in the workplace. So it's a more holistic assessment of trainee progression. We're asking supervisors and consultant colleagues who know you how much supervision you require for these different types of activities. And ultimately, by the end of training, you won't require any supervision. So you will be independent in practice and ready to become a consultant. And all of the generic and specialty SIPs or capabilities are mapped to the new GMC generic professional capabilities. And if you haven't seen those, it's worth having a look at those, and there are 9 specific domains. Can I have the next slide, please? So although I am the curriculum lead for geriatric medicine, I'm only going to use 1 or 2 examples. The comments that we're talking about today apply across all of the specialties. So all of these new higher specialty curricula build on the internal medicine stage 1 training, which, as you know, has already started. It's a 3-year role preparing trainees to be the medical registrar. And these internal medicine capabilities are included in all of our Group 1 specialty curricula. Following on from IMT, stage 2 internal medicine training will be integrated seamlessly with the rest of your higher specialty training in the dual training programs. And one of our main drivers for actually creating these new curricula is to ensure that we equip you as trainees and doctors of the future to manage unwell patients with complexity and multimorbidity. So my specialty is a geriatrician, but those types of patients are now being managed by all specialties, and we all need to have those skills to be able to manage them. Next slide, please. But there are some things about training that haven't changed. We hope that we're building on already good supervisory practice. The ARCP process will continue, and we will still be using supervised learning events and workplace-based assessments as a fairly key component as to how you and your supervisors evidence your progression through training. Next slide, please. So next slide again, please, just for a little bit more detail about what these capabilities in practice are. They're describing professional tasks. So what do you actually do as a hospital specialty doctor? You run outpatient clinics, you run an acute medical take, you might see patients in nursing homes in the community, but these are tasks that we all perform, and some of them are very generic and cross all of the specialties, and some of them will be more specific to specialties. So all these capabilities are based on what we call entrustable professional activities. What can the trainee be entrusted to do with what levels of supervision? And we're asking our clinical and educational supervisors to use their professional judgment as to where you are in that pathway between needing quite a bit of supervision to being independent at CCT. And as I've already mentioned, you need to be independent, unsupervised practitioners in all of the capabilities for your specialty by the time of CCT. That means you're ready to fly as a consultant. Next slide, please. Each of these capabilities is then further broken down into a series of descriptors, which describes in more detail what we mean by each heading capability. It describes the levels of the performance that we expect a trainee to be at the stages of their training programme. We map each of these capabilities to one or more of the 9 generic professional capabilities. And we also give an indication as to suitable sources or forms of evidence that might be used to inform these entrustment decisions. Next slide, please. So each capability has a set of descriptors associated with that activity or task, and they indicate levels of knowledge, skills, and attitudes which should be demonstrated. But they're not a comprehensive list. It's a pretty good list, but there are other ways of demonstrating competence. There are other pieces of evidence that you might use. So these are examples and guidance. They're not absolute and not completely comprehensive. Next slide, please. So, for example, there are the internal medicine capabilities. There are 8 of them, but just taking capability 4, that is the capability of managing patients in an outpatient clinic or an ambulatory care area or a community setting. And that breaks it down to saying, well, in order to run an outpatient clinic, you need to be able to demonstrate professional behaviour, shared decision making. You must be able to undertake a consultation. You must be able to do history and examination so that you can reach a diagnosis, create a management plan, and then explain that management plan to patients and or carers, taking account of comorbidities, as we've already mentioned, and having an awareness of what makes a good experience for our patient group. So this is a heading capability, managing patients in a clinic, and then these descriptors that help you understand what we mean by that. Next slide, please. So there are 3 types of capabilities in practice that you need to be aware of. Next slide, please. First of all, the generic capabilities, which cover all of the requirements required by every physician. So every physicianly specialty needs to be able to undertake all of these generic capabilities, and they are mapped closely to the GPC framework. Next slide, please. The internal medicine capabilities are 8 capabilities which run through IMT stage 1 into IMT stage 2, and they are also present in every one of the physicianly higher specialty curricula. And then finally, we have the specialty capabilities, and those will differ from curriculum. So the cardiology capabilities in practice will be different from the geriatric medicine capabilities in practice, but the other two sets will remain the same across all of the curricula. Next slide, please. So let's just have a quick look at the generic capabilities. There are 6 of those. And they look at things like management, ethical issues, professional judgment and behaviour, patient safety, managing data, research and acting as a clinical teacher. Next slide, please. And if we take one of those in more detail, we have, for example, functioning within an NHS system. We have a series here of descriptors which expands what we mean by that capability. Next slide, please. We then indicate which of the 9 domains of the GPC framework this particular SIP links to. And we also give some suggestions as to how you might be able to demonstrate that SIP when you're discussing with your educational supervisor where you are. That might here be a multiple consultant report, an MSF, a management course, or end of placement reports. Next slide, please. The internal medicine SIPs, well, there are 8 of those, which I hope you will be familiar with. They're the same as in IMT stage 1. Next slide, please. And if we take one of those, for example, managing an acute unselected take, again, it gives us an indication as to the sort of knowledge and skills and behaviours that you need to be able to demonstrate to do this successfully. Professional behaviour, accurate examination, appropriate clinical reasoning, diagnostic skills, selecting investigations, and liaising with people when appropriate. Next slide, please. And again, linked to the GPC domains, you can see there's more domains here. Numbers 1 to 6 are all covered by this particular capability. And the evidence includes case-based discussions, ACATs, perhaps a logbook of training, and an indicator of the simulation training that you've undertaken. Next slide, please. And finally, each of your specialties will have their own specialty SIP. So we have 7 in geriatric medicine. Next slide, please. And if we just look at one of those in more detail, managing community liaison and practice, again, the descriptors tell you what we mean by that. We're looking for the ability to perform all of these things in the community, a comprehensive geriatric assessment, managing acute illness, managing comorbidities, assessing capacity, medication review, again, diagnosis, problem list, management plans, and also identifying where there is limited reversibility of the medical conditions, discussing end-of-life care and palliative care needs. Next slide, please. And again, we link those to the appropriate GPC domains and give some suggestions as to the types of evidence that you can use to show that you are progressing in acquiring this capability. Next slide, please. Your curriculum, as well as having this list of capabilities in practice and what they mean and describing them and expanding upon that, will also have a syllabus. Each curriculum will be slightly different in how it presents this syllabus, but it effectively indicates the presentations and conditions that we expect you will need knowledge and understanding of in order to be able to demonstrate those capabilities in practice. So that is a much more extensive, if you like, syllabus of the knowledge that you will need, the types of conditions you will need to understand in order to be able to run an outpatient clinic or a specialty take in your own individual specialty. Next slide, please. So, for example, in geriatric medicine, our curriculum gives an indication of the presentations and conditions which show the whole clinical context in which those capabilities are demonstrated. And for each of these conditions, trainees need to understand etiology, epidemiology, pathophysiology, clinical features, investigation, management and prognosis. But unlike previously, you don't need to be ticked off for all of those individual, all of these individual elements. It's how you then apply those into the capabilities that will be assessed. Next slide, please. And just to give a quick indication, one of our elements is nutrition. So again, in the syllabus, we will expand the sorts of areas of nutrition as a geriatrician that you need to be able to do in order to be able to manage complex, frail, older people. So I hope, next slide please, that has given a sort of a bit of an overview as to what capabilities in practice are and how they differ a little bit from our tick box competencies that we have been using up until now. And I'm going to hand over now to Venkat, who's going to tell us a little bit more about how we assess those capabilities and the progression through training. Thank you.
Thank you very much, Sue, for setting the scene. I'm the co-chair for Rheumatology SAC and former curriculum lead. And we're going to talk about assessment of progression of these SIPs with the new curricula. When we talk about, next slide, please. We talk about assessments. So lots of scenarios are sort of trainees as well as trainers conjure up. And I think we are trying to move away from a tick box exercise into holistic decision making, as we are trying to say entrust our trainees so they can run an outpatient clinic, they can manage an unselected take, as we have seen, and they can manage emergencies, manage a day case unit, or manage community liaison. And the educational supervisor's report has got more weightage in these assessments. Next slide, please. In the program of assessments, it emphasizes the importance and centrality of a professional judgment of educational supervisors and clinical supervisors in the way of the multiple consultant report. This will make sure the learners have met the learning outcomes and expected levels of performance, which we'll go in detail a bit later. So we have sort of clear levels of performance depending on the training program, and the assessors will be accountable for their judgments. And these judgments are used to make these holistic decisions that our trainees are making adequate progress. Next slide, please. When we talk about holistic decisions, they contain the whole portfolio of assessments, outcomes available to rate the overall trainee performance. It includes your exit exam. It includes the day-to-day workplace-based assessments, which you're all familiar with, and the supervisor feedback. And we also have a section on trainee self-assessment. We will have a section on that in the e-portfolio you will hear later. Next slide, please. Okay, assessment of capabilities in practice. So go for the previous slide. Okay. The holistic decisions of by which entrustment decisions are made. It utilizes the different assessment methods which we are familiar with, and it takes into account the entire progress of the trainee made to ensure the decisions are fair, they're appropriate, and safe. So this takes an overall view rather than having multiple assessments for each competency in our current system. So we don't have to sort of tick so many boxes or do so many assessments, but over a period of time is to try and sort of go back to a period some time ago when a consultant knows that a trainee is capable of sort of moving on and to try and function independently as a consultant. So that's what we are trying to sort of come up with, the capabilities in practice and holistic decision making. Next slide, please. Okay. So the assessment of capabilities in practice depends on the global assessments, and there are anchor statements. Globally, what we are trying to sort of say using our generic SIPs, our supervised learning events, we've talked about workplace-based assessments and the multiple consultant reports. So we can say either the trainee is below the expectation for the year of training, they may not make it to the critical progression point, or they meet the expectation of training and they can go to the next stage, or they're above expectations of training and progress. Next slide, please. With this entrusted decision making about the capabilities in practice, we have different levels. Level 1 is a trainee who's just at the beginning. Probably we don't have many trainees at that stage unless they are new to the specialty or they are IM stage 1. They only observe in the clinic and they don't directly provide clinical care. So probably we don't have many in that stage. Most of the things, and I'll show you a grid for internal medicine as well as the specialty. It's level 2 when they start off in the specialty, entrusted to act with direct supervision, where the supervisor is immediately available on site if required. The next level is entrusted to act with indirect supervision, like an unselected take or out of hours on call, where the supervisor is available remotely to provide advice and can attend if necessary. And the final stage is they entrusted to act independently before they're ready to become the consultant. It's usually in the final year or the penultimate year. So you need to be very careful about that. Next slide, please. If you look at the grid we saw the CIPs for internal medicine, which Sue highlighted. So we've got about 8 clinical SIPs. But there are some examples now. We've heard that consultants are signing off IMT3 or ST4 trainees as level 4. They're not ready to become consultants yet. Unless you think this trainee can sort of start off as a consultant next week, you don't sign them as level 4 at this stage. So there are grids available for each specialty as well, as I will show that in rheumatology. But I think we need to be careful when we are signing off. And there is more weightage for the educational supervisor report. Next slide, please. So I was going to introduce some of the new sort of workplace-based assessments. People are familiar with case-based discussions and mini clinical examinations and directly observed procedural skills are standard workplace-based assessments. And trainees have been using an acute care assessment tool for sort of doing a ward round or assessments. But there's a new tool which is introduced, Outpatient Care Assessment Tool, OPCAT. This is introduced in 2021, waiting for GMC approval. You may not immediately find that in the curricula, which have been approved, but I think there is more information on this on the JRCPTB website. It is a useful one for the supervisor if you plan that to sort of sign off a capability of running the outpatients. And there are no number of patients which are sort of set out for this clinic, but at least trainees should have about three outpatients. It is not mandatory, but it's advisable to get structured feedback on your outpatient capability. I think that's useful, and I think outpatient specialties like rheumatology or dermatology make more use of that, but it's a SIP4 for internal medicine clinical capability as well. Next slide, please. Rheumatology, specialty specific SIPs. Next slide again. Next slide, please. Yeah. So we have about 7 SIPs in rheumatology as well, like they have in geriatric medicine. So there are 6 generic SIPs. We've got 8 clinical SIPs in internal medicine and about 7 SIPs. And it will make a total. So this works across rheumatological disorders in commonly seen rheumatologic emergencies, complex rheumatologic disorders, rarer disorders, practical procedures. We have a separate SIP in rheumatology that's different from other specialties, managing and leading a musculoskeletal MDT and coordinating with other specialties, and ability to manage the interface with primary care and patient groups. Okay. Next slide, please. We can look at this in more detail about the SIP2, which is managing rheumatologic emergencies. As Sue mentioned earlier, we've got these descriptors with appropriate behavior, which is given details, mainly focusing on consultation skills, including challenging circumstances, negotiating, shared decision-making, effective clinical leadership, and prioritization. When we've got multiple patients to see, an accurate diagnosis, appropriate continuing management in this sort of emergency setting, and it could be in intensive care, it could be in the ambulatory care setting, And we also incorporate appropriate use of investigations and planning evidence-based prescribing. And also testing the ability, how they can liaise with the rheumatology MDT as well as other specialty teams. Next slide, please. So we've got this generic professional capabilities. It covers 6 of the 9 GPCs, covering values, skills, knowledge, health promotion, as well as illness prevention, leadership and team working, patient safety, as well as quality improvement. And the trainees can show evidence using the standard workplace-based assessments, multi-source feedback, multiple consultant reports, and the knowledge can be tested with the exit exam, and they also can use the opportunity for reflective practice. But the weightage is on the educational supervisor report. Next slide, please. You could see the grid for the rheumatology specialty SIPs here. As I mentioned earlier, so in the early years, it's level 2. As they go to the final year, it's level 4. In some of the common ones like managing common rheumatological disorders and emergencies, the trainees could achieve level 4 in the penultimate year. But most of the other ones, we expect them to achieve that in the final year. And I think it's similar to what we've done, what we've seen in SIP, the SIPs in the grid for geriatrics as well as for internal medicine. Next slide, please. The multiple consultant report. Trainees work in different teams. You come across different supervisors when they're in acute medicine, when they are in their specialty. So getting feedback from different clinical supervisors is helpful to capture the opinion of different people who can sort of support this entrusted decision making. The respondents are requested to provide feedback on the trainees' progress against the capabilities and practice we have seen, but using the global anchor statements we saw earlier, meeting expectation for training, exceeding expectation for training, or below expectation for training, because that will feed into the educational supervisor report. One can't probably provide sort of feedback on each trainee on every SIP, but it's the trainee's responsibility to try and sort of gather this feedback over the training year. Okay, from very supervisors they're working with. I think this will sort of help us to try and make this entrusted decision. So the trainers on the call as well as the trainees need to understand this and to try and sort of make this work. Next slide, please. End of training assessment. As we said, the ARCP, not much change from the current arrangement, but towards the end of the training, the trainees need to make a self-assessment, and there is room in the e-portfolio for that. They have to record this and with signposting to the evidence what they've gathered to support that they've achieved this SIP. And the educational supervisors review the evidence in the portfolio and they complete the educational supervisor's report. And there is a structured educational supervisor's report and there's a section which will be covered later. But I think that would sort of help us to make entrusted decision. Okay. So there is further information and resources provided. Next slide, please. On the website, and we've got rough guides for internal medicine and specialties, highlighting the difference between the old and the new curricula, what is required from trainees and trainers, what are the types of evidence that can be sort of used to support your achievement, transition arrangements, you'll hear more about it shortly, and the ARCP process and decision aid. And the next slide, please. You have all the links on the JRCPTB site for you to look at. The small snippets of videos and this webinar will be available as well. And people can go through the guidance, and if there are any questions, people can try and we can address that in the panel discussion. Thank you. We'll move on to the next presenter, Dr. Miller.
Great, thanks Venkat, and good afternoon everybody, and thanks very much for tuning in or watching it on the replay later. So I'm Alistair Miller. I'm an infectious disease physician by background, but currently mainly working in acute medicine. And I'm going to be talking about the way that training in internal medicine is integrated with higher specialty training. So if we just have the first slide, please. Yeah, so this is the diagram that I'm sure most of you will be familiar with, and it shows how this whole program meshes together. So people come through foundation into competitive selection into internal medicine stage 1 training, which is a 3-year program, different from core medical training in that it mandates various experiences such as critical care, outpatient clinics, geriatric medicine, etc. And 2 years of that sort of generic medical training leads into IMY3, Internal Medicine Year 3, which is the year as the medical registrar, during which further training obviously is obtained, and during that period MRCP UK is obtained. There is then further competitive recruitment into the dual training in internal medicine stage 2 and the higher specialty training in a group 1 specialty. And I think all of this audience will be aware that group 2 specialties are already going. They started in August last year, and they may recruit after 2 years of internal medicine stage 1. And they are the specialties that traditionally didn't really get very involved in acute internal medicine. Whereas the group 1 specialties, or what you might call the frontline main specialties, no disrespect to colleagues in group 2, but these are the ones that have traditionally trained in and delivered the general medicine on the wards. And of course, as everybody will know, there are 3 specialties, which I'll come to later on, that are now moved from being traditionally group 2 type specialties into the group 1 routine. So that red circle there shows what we're concentrating on today, which is that dual training in internal medicine and specialty. Next slide, please. And this is taken directly from the curriculum for internal medicine, and it states what we viewed as the as what internal medicine, general medicine, whatever you want to call it, is all about. And it's producing doctors who have all those capabilities, both generic and clinical, to be responsible for the management of patients presenting with a whole wide variety of general medical symptoms and conditions. But next slide, please. What really is internal medicine? I mean, I think we all know what it is because we see it and we practice it day in and day out. But these days, there are no general medicine wards or teams or firms or whatever you like to call them. There are very few wards that are designated as a general medicine ward. But having said that, many patients on specialist wards will have problems outside of that specialty. So they'll have general medical, or probably more often there'll be geriatric patients, as we heard from Sue, on the specialty wards with general medical conditions, and usually many of them. So that's one of the problems. People will have multimorbidity, multiple comorbidities. There are no general medicine clinics. Nobody is referred to general medicine. Some people think that's a shame, but the reality is they do not exist. So the main thing that we want to get from people training in general medicine is that ability to first and foremost recognize that they are physicians, and to look at a patient from a holistic perspective and not from an organ specialist perspective. So we don't want a cardiologist to think that every patient who comes in with chest pain has ischemic heart disease, for example. We want cardiologists to feel that they can look after a patient with pneumonia without sending for a consult with an ID physician or a respiratory physician. We want a renal physician to feel they can look after somebody with cardiac failure. And that is the sort of underlying ethos of what we're trying to achieve with the internal medicine curriculum. Next slide, please. But inevitably, in postgraduate medical training, there will always be conflict. And the 2 conflicts that I wanted to highlight here is that there's always conflict between training and service. So, and they can't be really teased apart. I mean, if if a medical registrar is doing the acute unselected take, they are getting experiential learning. They are being trained, they're increasing their capabilities whilst they're doing that, but also clearly, very clearly, they're providing a service. And there are very few situations in which you can really divorce training and service. And in general, if the training is good, then the service delivery is good. And if the service delivery is good, generally they're having a good training experience. But there is always that conflict that people are saying, oh, well, you know, the trainees are having so much time doing the acute take, they're not having time to go to training. So that is a conflict. Possibly for the purposes of this webinar, the conflict that is potentially even more relevant is that conflict between internal medicine and specialty. And once again, it's a slightly artificial scenario in that if you are acquiring cardiology capabilities in a cardiology specialist clinic, you will be acquiring generic capabilities as well. You'll be improving your communication skills, your team working skills, etc. And also you'll be improving your skills and capabilities in general internal medicine. And similarly, if you're doing general internal medicine, you'll also be gaining specialty capabilities. However, within this internal medicine stage 2 program, everybody has to do an indicative 12 months of, quote, general medicine in order to ensure that they are properly trained. And inevitably, as I put on the bottom in that quote there, we've probably upset everybody in that the general internal medicine SAC felt that we were not putting enough emphasis on general medicine and putting too much emphasis on specialty. And many of the specialty SACs, particularly of course the craft specialties where they have to acquire a lot of procedural skills, felt that perhaps we were putting too much emphasis on general medicine. So Mike, Zoe, Phil, David and the rest of us have sometimes joked that as long as we've upset everybody, we've probably got the balance about right, and hopefully that is the case. Next slide, please. So again, in all these things, what we want to look at is what's the outcome. We're in an outcomes-based curricula. We need to think about what we're trying to produce. And the reality is that at the end, at CCT in a Group 1 specialty, a trainee on day 1 must be capable of independent consultant practice without supervision in both their specialty and in internal medicine. And I made the point there in the slide that we're not just talking about the acute unselected take. Clearly that is a highly important, pivotal part of internal medicine, but it's not the only part. The trainee must be able to practice in any sized hospital, and clearly there's a huge difference between arriving in a small hospital on the north coast of Scotland with 2 or 3 consultant colleagues and being appointed to a huge academic department in Oxford or Imperial. But you have to be able to, we have to produce trainees that can flourish in either of those environments. And finally, we have to produce trainees who are capable of subspecialty post-CCT development, because that's just, you know, getting your CCT, yes, you're capable of independent practice, but you are going to be developing subspecialty interests within your specialty. And the other big aim of training is that we must be able to provide the acute unselected take with the adequate and appropriate number of medical registrars. Next slide, please. So in order to try and ensure the appropriate experience of internal medicine integrated within higher training, the curriculum, and remember, of course, the curriculum is a mandate. This is a GMC approved document, and what is stated in the curriculum must be delivered. There's no optional bit about the curriculum. GMC have approved it, that's what you have to do. Whereas guidance that comes out from JRCPTB is just that, it's guidance. So as far as the curriculum are concerned, a trainee in a Group 1 specialty must see 750 patients with acute medical problems, presenting with acute medical problems over their whole of IMS2. Now, most people doing internal medicine will have seen that probably within the first year or certainly within the first couple of years. So it's not a a dramatic requirement. They need to see 100 patients fulfilling those criteria in their final year of training to ensure that, as I've said, when they, on day one, when they get their CCT, they can practice in general internal medicine. And to that end, in addition to seeing 100 patients in their final year, they must do either 3 months, during which time they're involved in acute unselected take, or they must do a 4-week block when they're fully immersed within an acute medical setup, whether it's an acute medicine unit or attached actually onto the emergency department, but they must be fully immersed in an acute medicine environment. Next slide, please. Moreover, they have to have 12 months of continuing care of those admitted with acute medical problems. And again, in the traditional Group 1 specialties, that's never going to be an issue because all of those specialties will have acutely unwell patients that, that the trainees will be looking after. Possibly a new thing which doesn't seem to have been too controversial is that we've mandated that trainees need to do at least 20 clinics in a specialty other than their parent one. And this is to get them to look at the other side of things, something I was talking about with some of the earlier slides, to make sure they just have a different perspective and they don't look at everybody through the lens of their own particular specialty. And those clinics can be all in one specialty. So a cardiology trainee might do 20 renal clinics, or a diabetic trainee might do 20 neurological clinics, or they can do several clinics in lots of different specialties. And then finally, and arguably one of the most critical things, is that every trainee, in addition to an educational supervisor in their specialty, must have an educational supervisor for internal medicine. And again, next slide, please. Next slide, please. Sorry. Yeah, so the guidance that that we've put on top of those curricular requirements are that, first of all, we've noted the GMC requirements that all timings and durations of attachments are indicative. That is, they are saying, or we're saying, that the average trainee will take 3 months to acquire this particular capability in this particular context, but some trainees may need longer, some may need shorter. As I've said, we're advising that for acute unselected take, trainees must be involved in that throughout their 4 years of higher specialty training, unless they're also involved on a specialty curriculum rota when they can reduce their AUT requirement to 3 years. And we've suggested that 1 AUT a month is adequate for training, but NB, this is not a minimum. This is clearly many trainees will be doing far more than 1 a month because of the service delivery requirement. And again, there in our guidance, we've emphasised the 12 months of continuing care and 20 clinics in the non-parent specialty. Next slide, please. Again, we've added further advice to the curricular requirement for educational supervisor. Every trainee must have an educational supervisor for specialty and an ES for internal medicine. Now, in many specialties, it could be the same individual, provided they're practicing both specialty and internal medicine. So for a gastroenterologist who's doing the acute take, practicing in internal medicine, that's fine. It can be the same person. But if it is a single individual, and if they're not themselves practicing IM, and we feel that's not ideal, but we recognise the reality, sometimes it'll have to happen, then it's critical that the IM, that the supervisor must obtain appropriate detailed feedback from clinical supervisors who are familiar with the trainee's internal medicine practice. Next slide, please. So of course we've got the so-called new Group 1 specialties of neurology, gum and palliative. And the first point I want to make here is their curricular requirements for internal medicine stage 2 are identical. They're all following the internal medicine stage 2 curriculum. But they may have, well, they probably will have fewer general patients on their specialty wards. So they need to spend 9 months or 12 months doing internal medicine, but 3 months of those are allowed within their specialty context. And I'll show how that happens on the next slide, please. Next, please. Yeah, so for neurology, 3 months doing hyperacute stroke is countable towards their internal medicine training. For GUM, 3 months on infectious disease or HIV wards is acceptable. And for palliative care, 3 months in an acute hospital-based palliative setting is acceptable. Next slide, please. I could spend the whole workshop talking about academic medicine and the particular problems of that, but I'm not going to go through this slide in great detail, but except for bullet point, well, the first 2 bullet points. First of all, academic trainees absolutely have to follow the full curriculum, so they have to be clinically trained in exactly the same way as their non-academic colleagues. And most important, I should have said this right at the start, because of the way the curriculum has been constructed, it is not possible to get a CCT in specialty alone. No cardiologist, no chest physician, no diabetologist can train in specialty alone as from August of this year. They cannot, quotes, drop internal medicine. And this may represent particular challenges for the academics who will need to train in their specialty in internal medicine and in academia. And we've suggested one possible solution for this is that they could train in internal medicine alone, because that is feasible. There is a standalone curriculum for internal medicine, but there is not a standalone curriculum for any of the Group 1 specialties. So I'll stop there and obviously be very happy to engage in the Q&A session at the end of this webinar. Thank you.
Thank you, Alistair. So my name's Rufa. I'm the ePortfolio manager, and what I will be going through is talking about all the ePortfolio developments to incorporate all the new changes that will be taking place. Next slide, please. Next slide, please. So the ePortfolio developments to support the new curricula. So all the changes that we will be making will be on the same ePortfolio that you currently use and familiar with. To highlight the key changes that we'll be making, we'll be introducing the new 2022 curricula for all the Group 1 specialties. We'll be creating a new education supervisor report for all these specialties, and also the special specific multiple consultant report. What we'll also be trying to develop is a summary of progression page for each specialties, and also where each specialty has existing or new special specific assessment forms, we will also be creating those. Next slide, please. So, as you heard in the earlier discussions about the new curricula, this is an example of how the Geriatric Medicine, Internal Medicine 22 Capabilities and Practice curriculum will look. It's very similar to how the current curriculums look and feel. These will just display the additional generic capabilities, internal medicine, specialty, and any specialty specific ones, including practical procedures where applicable to your specialty. Next slide, please. So for each of the ratings, for the generic SIPs, as you can see, they'll be rated as below, meets and above expectations. For the internal medicine clinical SIPs and the special SIPs, they will be rated level 1 to 4. Next slide, please. For those specialties that do have practical procedures, these will be the standard ratings that will be applicable to your specialty to rate any of the practical procedures the trainee undertakes. Next slide, please. So for the new education supervisor report, again, these will be designed for each specialty. They will incorporate the generic and special SIPs. What we'll also be developing is a separate education supervisor report for internal medicine. The report will auto-populate the latest ratings and comments made by the education supervisor, and this will be taken from the curriculum page. The education supervisors must ensure that they update the curriculum page with the latest ratings and comments for each of the SIPs prior to creating the report. Next slide, please. So how will the auto-population work? So this is just a quick overview how we will develop this form. So for the education supervisor report to work, the supervisor will need to rate and make comments on the education trainee's progression on the curriculum page. What will happen is once they've added the supervisor's ratings and comments, as you can see from the image, when the education supervisor report is created, all the data will be pulled through from the curriculum page and into the supervisor's report, and it will display what the latest rating comments was made by the supervisor. Next slide, please. So here is an example of how it will populate. If you look at the red arrows where it's pointing, these are the areas and the sections that we auto-populated onto the ESR report. So I've given an example of the generic SIPs. So once they are rated on the curriculum page, it will be auto-populated in the supervisor report, and it will also display the comments that was made by the supervisor. It is very important that supervisors, particularly the education supervisor, makes the ratings and comments prior to creating the supervisor's report. The form, however, can be saved in draft. So if you do forget for any reason to update the curriculums, or you feel you need to make adjustments, you can save the form as draft and then go back and update the curriculum page, and it will then refresh and update with the latest ratings and comments. All of this will remain in drafts unless you save the form as final, then you won't be able to make any further updates to that particular form. Next slide, please. Also on the supervisor report, we will have a section where it will summarise all the evidence of all the assessment forms that's been done. This will auto-populate the total number of assessments completed within the date range the supervisor report covers. Each specialty will have its own requirement, and this will be detailed in each form, and it will auto-populate in each of the sections. Next slide, please. The multi-consultant report, again, will be designed for each specialty, and it will incorporate the generic internal medicine SIPs and the specialty SIPs. The form must be completed by consultants or associate specialists or specialty doctors who are able to provide feedback on the trainee's clinical performance. The MCRs will be collated and summarised in the MCR year summary sheet, so that will give the overall summary of all the MCRs, individual MCRs that have been completed, and be summarised for the supervisor and the trainee to view. Next slide, please. Here is an example of how the new forms will look. So again, as I mentioned, it's specific to each specialty with their clinical SIPs and specialty SIPs and internal medicine SIPs. So this form will be required to be externally ticketed. So each trainee will need to send a ticket to a clinical supervisor or appropriate associate clinician to fill in this form. Next slide, please. The new summary of progression page is designed for each specialty, and the requirements will be sectioned to reflect the ARCP decision aid. There will be sections where it will auto-populate all the data and display the latest information that is taken from the portfolio. This page will be used for meetings between the supervisors and trainees, and also when the ARCP takes place. Next slide, please. So here is an example of the summary of progress page, which we developed for IMT. The idea is we will take this as a template and we will modify it so it covers for each specialty. So each requirement will be taken for the ARCP decision aid for each specialty. Next slide, please. So taking the IMT summary page example, so each section will be taken from whatever the requirement is from the decision aid, and it will auto-populate the data, and it will show what evidence has been produced and displayed here automatically. Each section will populate the data if there is data recorded in the portfolio, and where there are specific targets, there will be indicative requirements for the trainee to meet, and if these are met, then there will be a green icon or traffic light and will be displayed, which will indicate that the trainee has met that particular requirement, and this will be reflective for each year of training. Next slide, please. Just to give you an idea of when we will be implementing all these changes, so for the new curriculums and for the multiple consultant report, they will both be developed and they will be live for August 2022. The Education Supervisor report is expected to be delivered later this year or in Q1 next year. And for the summary of progression page, we aim to deliver this by Q2 next year. Next slide, please. Thank you very much. I'll hand over to Zoe Fleet.
Thank you very much, Reefa. My name's Zoe Fleet. I'm the Curriculum Assessment Manager for the JRCPTB, and I'm going to talk to you about transition of current trainees to the new curricula. Next slide, please. So the GMC has updated its policy and given a statement on how learners should transition to the new curricula. So it's in the interest of patient safety and maintaining educational quality. The doctor should be trained and assessed against the most recent standards for the specialty. For that reason, doctors in training should move to the most recent GMC approved curriculum as soon as is possible. Next slide, please. There is flexibility allowed in the policy, and this allows for doctors in their final year of training to not have to transfer, and that is pro rata for less than full-time trainees, so maybe more than 12 calendar months. It also recognises that some cohorts of trainees may experience a greater impact than others and might need longer to prepare and to transfer to the new curriculum. It's important to know that if it's not in the interest of patient safety or would be impractical to support a move to the new curriculum, a trainee may remain on and complete on the previous curriculum. We'll talk about that a little more. Additional flexibility has been agreed with the GMC for a number of our specialties because of the degree of change to the curricula, and I'm going to talk about those in the next few slides. Next slide, please. So for our new Group 1 specialties of genitourinary medicine, palliative medicine and neurology, these are specialties that haven't previously dual trained with internal medicine, so there is a more significant change to their new curricula. For this reason, trainees who are in these specialties prior to August 2021, they will not be mandated to transfer from the single training programme to the dual CCT training programme. Additionally, trainees who enter palliative medicine from general practice or anaesthetics would not be required to transfer. However, trainees should be encouraged to and supported to transfer where they wish to and where it is possible. There's guidance on this on these specialties web pages that would encourage people to have a look at. Next slide, please. For cardiology, again, a provision has been made for those doctors who are in cardiology only training so that they are not mandated to transfer from single training to dual CCT programs. But again, they're strongly encouraged to do so for the reasons outlined before. Trainees appointed to dual programs should not be dropping GIM, that's general internal medicine, unless they're supported to do so by their training program director, head of school, and it must have postgraduate dean sign off. Next slide, please. For acute internal medicine, a 2-year transition period has been agreed. This is because there is a requirement in the new curriculum for trainees to acquire ultrasound competencies. And it may not be possible for trainees currently in AIM training to do those in time, and therefore they can complete on the previous curriculum. And finally, for clinical pharmacology and therapeutics, there are a number of trainees who are training in that specialty alone or in dual CCT programs that are not with internal medicine. And these trainees should be considered on a case-by-case basis. Next slide, please. So just want to talk through the principles for transferring curriculum. The majority of trainees should be moving to the new curricula and less in the new Group 1 specialties. It's recommended that trainees transfer at the start of a training year. That may be, that's most likely to be August for the majority of trainees, but maybe later than that. It doesn't make good sense to transfer a trainee partway through a training year, so that should be taken into account. The postgraduate dean must give approval for a trainee to remain on the previous curriculum if they're not in their final year or covered by the specialty-specific exemptions that I've just outlined and that are detailed on our website. A trainee's transition status should be documented on the e-portfolio by the deanery. It's recommended that this is done at the 2022 ARCPs, and there will be some communications around this in the coming weeks. Next slide, please. Just want to touch upon the gap analysis. So educational supervisors should be reviewing the new curricular requirements with their trainees and identifying any gaps that may need to be addressed. To do this, should refer to our transition guidance, and each specialty webpage will have the curriculum, the ARCP decision aid, the rough guide, and any other supporting guidance that will be helpful for this process. The gap analysis will help to tailor the training programme locally to ensure the trainees encounter the relevant learning experiences. And a record of gap analysis and transfer to the new curriculum can be completed on the portfolio for reference. It's worth bearing in mind that for many of our curricula, there has not been significant changes between the previous curricula and the new one, and the gap analysis can be relatively light touch. Next slide, please. So in terms of next steps, ensure the curriculum status for each trainee is agreed and recorded at this year's ARCPs or soon after. We'll be working with the 4 nations statutory education bodies to confirm which curriculum trainees will be on for the next training year and when that training level year starts. And the e-portfolio accounts for these trainees will be updated with the relevant programme, curriculum, and forms that are needed. It's worth emphasising that trainees will not be required to relink or transfer evidence from the previous curriculum to the new curriculum. Everything will be visible and accessible and can be referred to, but the process should not be onerous. And again, we'll be providing guidance to support that. Okay, that's my talk about transition. I'm going to hand over to Raghu now. Thanks.
Afternoon. My name is Anantakrishnan Raghuram. I'm the head of the Postgraduate School of Medicine in 7. So you've heard a lot about what the curriculum says and what the specialties have done and we've done, but this is the business end of it, how we're going to implement it on the ground. And we've been planning for this for several years, and I'm just going to take you through a very personal journey of how we've done it in the 7, and I'm sure this will be replicated in the rest of the country. So I'll start with placements. So when we had new Group 1 specialties, we suddenly had to find places for them, and it took a fair amount of negotiations to get the attachments for the specialties, and Mike and Alistair have gone through some of the arrangements. But in practical terms, we've had to find the money, we've had to find the supervision, we've had to find the support and the faculty to do it. And we are in very advanced stage of identifying those. The second part of that equation, and I think this applies to almost all the Group 1 specialties. There is, as Alistair pointed out, a tension between delivery of various aspects of a curriculum. Where there were 2 curricula coming up with a varied amount of attention to detail, we now have one integrated curriculum with the internal medicine spine with the specialty around it. So delivering that in a finite period of time has been a significant challenge for a number of trainees and trainers, and we're working through this. So Alistair mentioned this indicative period, and it is indicative. And one of the important conversations I've had as head of school with most of the training program directors, and my GIM lead is having those conversations, is to work out how in practical terms we're going to manage the seemingly competing demands on fairly finite amount of time to deliver everything that the curriculum requires you to do. Then there's the faculty time and the faculty ability to supervise. So Alistair mentioned about separate education supervisors for internal medicine. Now, yes, a number of subspecialties no longer take part in the general medical take. So one thing we have done and recommended is to have local faculty groups of clinical supervisors, in not so much the named clinical supervisor, but certainly people who have supervised you clinically to make a global assessment. And I'm going to move away from SIPs and sign-offs and actually take you to the end, take the trainee to their CCT and demonstrate there what the capabilities are going to be. And everybody is in a different stage in that journey, and work backwards with your supervisors to see what can and can't be done. And then we will get there. And time is indicative. Various trainees progress at different levels, and we have to adhere and adapt to individuals. Now, against that, and Alistair touched on this, is the very real problem of managing the take. Now, if everybody went down to do the bare minimum of the take, and I'm coming to the rest of internal medicine in a minute, then those who are left behind will have a more adverse training environment and will have their own effect on their training as well as on their work. And there has to be a part of this process, and the conversations we've had with the medical directors and the leads in the various medical departments is how they're going to manage the delivery of the take, the management of the patients, both inpatients and outpatients. Which brings me on to something else about the outpatients. It has been a major challenge for us, and something we are watching very carefully is simply the amount of space and supervision that is required to deliver the take and to deliver the outpatients. And again, rather than get hung up on absolute numbers, we want to see what the end looks like and can that capability be delivered. And then we're encouraging the medical directors in our region to look and see how that provision can be done. So in summary, landing this is a team effort. We need the employers, the medical managers, the training program directors, and all the education supervisors and college tutors to help and work us through this. The great advantage is many of the trainees, of course, have come through stage one and are quite familiar with this curricular requirements, and there are a significant number of trainees who are transitioning in. And my advice to all of them is seek out support from your education supervisors and your program directors. We're here to help. We will get there, and we will help you through this. And regular meetings with the supervisors, and I certainly run in the 7 regular meetings with the training reps. And it's a source of good information, but more importantly, it allows us to understand where the problems are, and we'll make it work. I'll stop there. Thank you.
Thank you, Raghu. Okay, I made the mistake of not introducing myself right at the beginning. I'm Mike Jones. I'm the Medical Director for Training and Development at the Federation of Royal Colleges of Physicians, and we're now joined for the question and answer session by David Marshall, who is Head of School in Scotland for Medicine, and Phil Bright, who's the Head of School in the West Midlands and the National in England HE Advisor for Internal Medicine. We've had quite a few questions asked already, and what I'm going to try and do is get each of the members of the panel to look at different aspects of questions. And maybe, Raghu, I could start with you, looking at the outpatient clinics where people are doing internal medicine, but they're supposed to be doing outpatients in other specialties, and yet some people could be quite late on in their training. How are those outpatient clinics going to be organised? Will there be recognition if people are late in training about the need to change numbers that are advised? Raghu.
Thank you, Mike. And this has come up, and apologies for not touching that in my presentation. What we want is an assessment of how people can manage on the general internal medicine clinics, because the old GIM clinics don't exist. So there are some very clever ways we can work this through. So having unscheduled care and having SDAT clinics would help. Having the ability to go and do related clinics, joint clinics, we don't quite allow. But although the indicative number was 20 over the period of 4 years, what we want to do is to come back to that original principle. At the end of the CCT, are you capable of managing a clinic in a specialty beyond your own? Not to the level of that subspecialty trainee, but your assessor and your supervisor makes that global assessment based on the OPCAT, based on the clinics that you've got. And the genetic skills are still the same, but understanding how the rest of the patient works is extraordinarily helpful. And I think a practical way around is for you and your educational supervisor to sit down and work that through and see how the transitions can happen. Thank you.
Thank you very much, Raghu. Alistair, could I come to you, because there are questions for those involved in the what we're calling the new Group 1 specialties, in particular, just the amount of internal medicine that those in the new Group 1 specialties will be needing to do, because there's been somebody from neurology and also somebody from palliative medicine asking for clarification.
Yeah, great. Thanks, Mike. So as was said at the outset, people have to do an indicative 12 months of internal medicine. And although we'd have quite liked at JRCPTB, we thought it would be very helpful if people did, say, 6 months in a completely different specialty from their own. So cardiologists went and did 6 months attached to a respiratory firm, or diabetes trainees went and did 6 months attached to a cardiology unit, or whatever. It was just felt that was too much and wasn't going to be practical, and we quite liked the idea, but it had a lot of pushback from specialty colleagues. So people training in the specialties can gain a lot of their internal medicine capabilities whilst attached to that particular specialty. But for the 3 new specialties, that was felt less likely to be the case, because neurology, palliative and gum are less likely to have quotes general medicine patients on their wards, in their units, etc. So that's why we made the stipulation that for those 3 new specialties, they had to do basically the 12 months of pure general medicine. However, because again of the tension between how much time people spend in specialty, how much time people spend in generalism, we relaxed that slightly to suggest that 3 months of that 12 months of internal medicine could be gained by working in their own unit. And I think I put a slide up showing how that works. 3 months working in a hyperacute stroke unit is countable. I hate using the term countable or counted, because we're not meant to be, quotes, counting experiences, months, weeks, or anything like that. We're meant to be looking at outcomes, but inevitably there is a bit of experiential counting that still goes on. So for neurology people, 3 months in a hyperacute stroke unit, which clearly there's a huge amount of general experience there. You're seeing people with heart failure, with pneumonia, with all the other complications that people get after an acute stroke. So 3 months in HAZU is, quote, countable towards general medicine training. For the GUM physicians, 3 months in an infectious disease unit Obviously, there are fewer patients with HIV as inpatients these days, but general infectious diseases obviously comes within the ambit of genitourinary medicine. So a trainee can do 3 months on an ID unit, and that will count towards their general medicine part of their combined training. And for the palliative physicians, again, they need to do a full 9 months of quotes pure internal medicine, i.e. attached and embedded in, I don't know, a chest team or a renal team or a combination of those. But 3 months whilst they're actually doing acute palliative work in an acute unit in an acute hospital is countable. And I said inevitably this is to compromise in that tension between how much time is spent doing internal medicine training and how much time is spent doing specialty training. So I hope that's clarified it and answered those questions, because it has been a process of negotiation and compromise between internal medicine and specialty. But I think we've achieved, so we've upset everybody, so we've probably achieved the right balance.
Phil, you have your hand up.
Thank you. So I think it's worth appreciating the enormous change in the demographics of the population for which we are going to have to care that is coming to the UK. Enormously. People are going to be older, they're going to be more complex. Even those who are not older are going to be more complex. And although reaching the curriculum minima will make you adequate, none of us really want to be adequate. We want to surpass adequate, and usually by some way. I have had lots of conversations with medical directors, a large number of which are in tertiary centres, and they are pretty much saying the day of the pure specialist is in the past. They are looking to make physician appointments for those who can do and deal with the intellectual complexity of the changing demographic of patients. So people that have the ambition to be just pure specialists, who see GIM as being almost a irritation, that's not the sort of jobs that are going to be around, and is not what medical directors are looking for in appointing consultant physicians.
Okay, thank you for that. In actual fact, Phil, can we just come back to you about supervision for internal medicine? Does the supervisor, the educational supervisor, always have to be doing the acute take? And indeed, does it always have to be a consultant who is signing off on workplace-based assessments, or indeed providing supervision?
Thank you. So there is the ideal model, and then there's the practical model. I think the ideal model is that everybody has 2 educational supervisors, one for general internal medicine outside of their specialty, and one for the specialty. That would be incredibly difficult to resource. The next best model is, where possible, the educational supervisor, if it's the same person for GIM and specialty, the educational supervisor should be engaged with GIM and particularly engaged with the acute unselected take. But again, where that is not possible, then someone who has a good understanding of the GIM curriculum can be the GIM educational supervisor. But these are strata of best practice. And I'd say again, best practice is actually for 2 people, particularly in those specialties where the consultant in the primary specialty is perhaps not as versed in general internal medicine as they would be in other specialties.
Thank you for that. Moving on from that a little bit, many trainees that will transfer to the new curricula will have had competencies recognised, and indeed certainly within practical procedures they will have had those signed off. What happens when they move to the new curriculum? Will they have to do all of these again? And so what is the possibility as regards the transferring of competencies? Sue, can I pose that one to you, please?
Thank you very much, Mike. So the simple answer is no, you don't need to do it all again. Everything that you have already done will count towards your current training. So although we're moving curricula, all of the stuff that you've done is still evidence that you can use to discuss with your educational supervisor and to look towards where you are in your capabilities. So Rifa may be able to help us with exactly what will pull through e-portfolio wise and how that will look, but certainly absolutely everything that you've already done, all the experience you've already gained, all of the workplace-based assessments you have already done remain completely valid.
Thank you, Sue. Rifa, would you like to pick up on the e-portfolio aspect of that, because it is a common question coming through?
Yeah, of course. So with regards to the portfolio, so we are developing the supervisor's report, which will pull in all the information from the curriculum page. So all the curriculum ratings and comments made by the supervisor, they will get populated. All the assessment forms that are completed, they will get populated again. So depending on your specialty. What we don't expect is anyone that's transferring from the old curriculum to the new curriculum, we will just park those and then start afresh with the new curriculum with the new ESR forms, because the new ESR forms will not pick up on the old assessment forms. So that's a slight difference. So when you are transferring to the new curriculum, you'll be assigned new assessment forms particular to your specialty. So when you are doing these assessments, they will only be applicable for the new curriculum only.
Thank you very much. Moving on from that, because we're now going into this area where we're looking at SIPs, there are two questions. First off, how many workplace-based assessments or SLEs are going to be necessary to prove a SIP? And secondarily, when we're looking at SIPs, how can a trainee be at level 4 when they're actually just finishing IMT, as we would suggest for SIP 7, for instance? So who would like, how about if we ask Venkat to come in on that?
Thank you. Thanks, Mike. I think with the SIPs, the number of workplace-based assessments, it's not sort of stipulated, not like the old competencies. We have to have numerous workplace-based assessments. For example, in rheumatology, we have an indicative number of 3 or 4 over a year. So that's the minimum. Some trainees can do more or less. And I think it's overall what feeds into the multi-consultant report and the educational supervisor report, where you can demonstrate that you are competent in this thing. It's not the number, the quantity, it's the quality of the educational assessment that matters. Okay. And the second part about the SIPs, and to try and address the query, if you sort of clarify that again, what was the...
Sorry, yeah, because there are a multiplicity of SIPs, the question has been asked, you know, how can you be level 4 in a SIP when you're just finishing IMT, for instance?
Yeah, I think in the IMT stage 1, so what they did was the 7th one, I think they are sort of ready to progress to IMT stage 2. That's what the level 4 meant there. And I think we have to look at the stage of training and where the trainee is. So we were talking predominantly about the IM stage 2 and the specialty SIPs today. In these ones, the level 4 is when they're ready for the consultant. But the IMT 1, it just says the end of that stage of their training and they're ready to progress to the next stage. That's how we probably need to interpret.
Yeah, I think it's also fair to say that with certain of the SIPs, we would expect people to be at a very high level. I think many people have said that we'd rather have the medical registrar conducting the acute resuscitation rather than it being a consultant. Now, that's no aspersion about any consultants in the land, but the medical registrars are probably getting more up-to-date experience and therefore probably are totally competent at doing that. So that would indicate why they're at level 4 for that. Sue, you've got your hand up.
Yeah, thanks, Mike. I just want to put in some of my thoughts as well about the first question you asked, Venkat, which is we're trying to get away from numbers. So we're trying to get away from I've got 3 CBDs and a couple of mini kexes. So I'd like you to sign me off this capability. To me, it's much more around a conversation between a trainee and an educational supervisor. So let's take that capability in geriatric medicine that I used as an example around community practice. So we foresee an educational supervisor and a trainee in geriatric medicine sitting down together. The trainees are asked to rate where they think they are with each capability. So do you think you've acquired this capability in community practice? Are you ready to become a consultant, or are you somewhere between just starting and being ready to become a consultant? If you think you're ready to become a consultant, well, what sort of evidence might you have to demonstrate that? Well, I've done an attachment with hospital at home. I've done a whole number of ward rounds in care homes, and I've got an OPCAT or an ACAT to show that I'm able to do that independently. I know how to do, medicine's reconciliation and how to do assessment of capacity. And I've got a couple of workplace-based assessments that show that, and I've been on this course. So it really isn't about saying I've got 3 of these, therefore I can do that. It is much more of a holistic conversation, I think, about where do you feel you are in training. Yes, well, I would agree with you with that as a supervisor, because your MCRs reflect that, your workplace-based assessments reflect that, and your portfolio reflects that. I don't know if that helps, but it helps me, I think, to understand what we're trying to get across.
No, I think that's very fair indeed. Phil, can I come back to you? Because in actual fact, somebody's saying about West Midlands. So ARCPs, how often are they going to occur for internal medicine? And somebody's also asked if one of the SIPs is not at the level in the decision aid, would that mean that would stop them progressing to the next year of training, or would it be a more overall assessment within the ARCP? So could you run through ARCPs, how you see them?
Okay, thank you. So ARCPs have to happen in both programs for which you're training. That means in general internal medicine and in the specialty program every year. And an ARCP should be entered even if you're on maternity leave, paternity leave, or even if you are on an OOP. Now, whether that is a combined ARCP, i.e. a combined panel, or a separate panel, there is some debate. And there are arguments for having either. The arguments for having a separate panel is that the GIM is properly looked at and a proper decision made. But the downside is the communication between the GIM panel and the specialty panel and the outcome. For having a combined panel, you've now got perhaps the GIM taking a backseat in the decision making, but it overcomes the communication of outcome between the 2 programs. What many head school are looking at is not to have pure one or the other, mainly because there is quite a high resource implication for having 2 separate panels running all the time, but perhaps to have combined panels in certain specialties for certain years and separate panels in certain specialties for certain years. That makes it more complex, but means in the real world of having to allocate the resources for doing this, it's probably more doable. In terms of the actual outcomes from the ARCPs, if you hadn't progressed in a particular capability, that's probably going to be indicated as an outcome 2, rather than you needing extra training time, unless there was a significant lack of progress, at which point the panel may agree that having some additional time at that point in the programme was beneficial to a trainee.
Thank you, Phil. Raghu?
Just to add to what Phil says, and that's absolutely the key here. What we don't want to do is to reinvent the wheel. But GIM has some very specific points where I think it is of benefit. And one of the things we've done in the 7 is in the first year, that is IST 4 year, it'll be good to have a GIM assessment, and we do that. Again, in the so-called penultimate year, there is a good time to look to see what else needs to be done. In the intervening years, it may be very difficult to get practically to have 2 panels. So what we like to do, and one simple solution might be to have a representative from another specialty who's comfortable with the IM curriculum to sit in on the panels in the other years. Now, there are some specialties, particularly new Group 1 specialties, where the supervisors and the RP panel may not be comfortable or have the breadth of understanding of the IM aspect of the curriculum. In that case, then we'll have to get somebody to do that. So it's not one size fits all. It is not prescriptive. But what we want to do, and I said this before, is to start from the end and work backwards and see how we can help them through that journey. And if we do that and have enough representation at every year's assessment, I mean calendar year rather than training year, and that will enable the trainee to have the conversation with their supervisors of what else needs to be done. And I think that's a pragmatic way around this, and we'll see how it works.
Okay, thank you very much. Zoe, a lot of questions coming up about CSER and the relevant parts of transition, and also the proportionality for less than full-time trainees. Would you just go over those for us, please?
Yes, thank you, Mike. Yes, there is information on our website about CSER and how the implications for CSER applicants of the new curricula. I will circulate the link, include it at the end. In the transition page, there is a link actually from one of the links in this set of slides. Basically, there is a transition period. So during that time, an applicant can apply to be considered against either the previous curriculum or the new curriculum. Particularly for the Group 1 specialties, applying for CSER will mean being able to demonstrate level 4 capability in the internal medicine clinical capabilities. By demonstrating that, the applicant will get 2 CSERs. So they'll get CSER in the specialty plus internal medicine. But taking into account the degree of change, there is a window of approximately 2 to 3 years in which applicants can apply against the previous curriculum and get a CSER in that specialty without internal medicine. In terms of sort of broader transition questions for trainees, I'd really recommend having a look at our transition guidance, having a look at your rough guide for your specialty and the curriculum itself, and familiarising yourself and seeing, starting to identify if there are any areas of training that you don't feel you haven't covered in the training programme to date, and discussing those with your supervisor as part of that transition plan, a sort of very individual plan. Was there any other aspects, sorry, Mike, that you wanted me to cover?
Yeah, there was one other question about somebody in acute internal medicine who's doing ultrasound as their specialty skill at the moment, but of course a point of care ultrasound will be part of the new curriculum. Does that mean they need to select yet another specialty skill to complete the curriculum?
That's one of the reasons why there is a 2-year transition period, to take into account that, because it wouldn't be appropriate to try and take on another specialty skill at that point. So they can complete on the previous version of the curriculum with ultrasound as their specialty skill, unless they want to have a conversation about the possibility of being able to do an additional one in the time left. So I'd just recommend having that conversation locally.
Excellent, thank you. David, I think you're back with us. Yes, you are. Could you just go over the timings to complete training, and including a number of people are expressing concerns that they have to do some internal medicine in their final year when it might interfere with their specialty training. So 2 aspects to it. Can people accelerate through training, or could it actually be that they have to take more time for training? And secondly, why internal medicine in the final year?
Well, I'll take the second point first, Mike. I think why we have medicine in the final year is fairly self-evident, that if you're going to be exiting with a CCT and be expected to provide the sort of skills that we're looking for from the new consultant from this sort of curriculum, then to not have any medical experience in your final year really would be inappropriate. There was a lot of discussion as to whether the 3 months or the high intensity 1 month would be sufficient. I think Alistair mentioned that in his presentation in great detail. And that it is within the curriculum guidance that you can have a high intensity 1 month period. What's interesting from our discussions with particularly the new Group 1 specialties have been that majority have stated they would prefer to have the 3 month period of medicine rather than a highly intensive 1 month, given that they are the sort of training that the new Group 1 specialties are experiencing is quite different from those previously. With regards the accelerated or delayed CCT argument, a lot of it comes down to capabilities. If you are able at your ARC-P to show that you are achieving your capabilities at an accelerated rate, then there is the possibility of bringing your CCT date forward as a result of that. It has always been the case that we have not actually recently had time relevant curricula. It's been capability or competence based, but that is much more so now. So if a trainee is progressing at a rapid rate and is showing their capabilities at their ARC-P through their educational supervisor's report, then it is perfectly possible that their CCT date could be brought forward. Equally, if a trainee is showing that they're needing a little bit more time to develop the capabilities that are required, then the CCT date may well be pushed back. So it's down to showing capabilities. It goes back to Sue's very elegant presentation that we heard earlier about what capabilities in practice are all about. And it's about showing that a trainee is achieving the requirements to achieve a CCT. Ultimately, it's not about the time that it takes to get there or the number of workplace-based assessments that it takes to get there. We're moving away from the tick box number counting towards holistic capability. I hope that answers that question, Mike. Mike, you're on mute.
Fine, I'd switched myself off during your exposition there, so I apologise. Yeah, Alistair, could you tell me what training for the trainers is available for this new approach to holistic assessment and what's been put in place to try and ensure people are aware of this?
Yeah, sure. Thanks, Mike. I mean, the first thing to say is that the concept of the holistic assessment has been around already because it forms part of the internal medicine stage 1 curricula. So we did road shows, I guess 3 years ago, two and a bit years ago, when I think between Zoe and myself and Tom Baker from education, a whole crowd of us went around the country and presented on this new concept. So hopefully that produced a bit of a foundation for people to be aware of the new style of assessment, if you like. And you know, the whole principle is getting away from that comfort blanket of ticking boxes and saying, yes, they've done 6 assessments at this and 3 months of this and 3 months of that, and actually looking at, so I think the description that Sue gave just 10 minutes or so ago was absolutely brilliant. I mean, that's exactly what we're trying to do. It's that holistic assessment, looking at everything feeding in. So the training has been around for a long time. It's on the website and the presentations that were given there are there. There's a whole slide set about the way that this is done, and that's being continually updated because obviously there may be people who are educational supervisors and clinical supervisors in Group 1 specialties who weren't involved in IM Stage 1 and therefore didn't have the benefit of that training previously. So, as I said, there is a whole new training package out there on the website, and I'm not sure whether we're going to be able to do a whole new set of roadshows or not, but I think that we will obviously try and provide further training to people who need it.
Okay, thank you. A lot of questions still about being out of program, doing a variety of experiences that people will come back at the start of their final year, but may not come back until 2023. What would be the advice given as regards what curriculum they should be coming back to in 2023? Zoe, would you like to take that again?
I've just said to refer to the guidance again. Being out of program doesn't mean that a trainee shouldn't transfer to the new curriculum. As we said, it's just trainees who are in their final year, but there is flexibility there. So I think it comes down to a local discussion. The trainee and the supervisor and the highlight to the program director and head of school if there are good reasons for a trainee to remain on a previous curricula, and make sure that it is going to be down to the postgraduate dean's discretion as to whether a trainee remains on the previous curriculum or transfer.
Okay, thank you. Just on the discussion point of view in the gap analysis, that of course needs to be recorded. Where do you see the gap analysis being recorded at REFA? Can I come to you and then we'll come back to Alistair and Phil?
Yeah, so the gap analysis, there is a form on the portfolio, and it's applicable for all specialties. So if the trainee is having discussions with their supervisor and they need to record whether they are transferring or remaining, the gap analysis form is a very simple, straightforward free text box. Just to have a discussion with the supervisor and identify where you've met the capabilities, where things are outstanding or you need to meet, and then make a holistic decision on whether to transfer. And that remains on your portfolio, and that will then be reflected on, your next ARCP to make sure that decision to be made. And if you are transferring, then your portfolio will then be updated to reflect that. So you'll be set up on a new program with the new program, with the new curriculum and all the assessment forms relevant to the new curriculum.
Thank you, Refa. Alistair.
Yeah, thanks, Mike. Just to add to what Zoe said, I think she's absolutely right. I mean, people need to be looking now at where they consider that their best options are. And I think there are two things. First of all, they need to have we're clearly talking about predominantly people who perhaps have not been doing internal medicine previously. They've been on a specialty alone curriculum and are going to come back at the end of their OOP-R or OOP or whatever, and potentially have to transition to the new curriculum and therefore will have to do internal medicine. I think there are 2 points there. Number one is they should have a good think about how difficult or not it would be to get those internal medicine capabilities and come out with the joint CCT in internal medicine and specialty, because it may well be that their future employability and employment options and things are very much better if they are duly trained. So they need to look at just, it's very easy to say, oh, I don't want to do internal medicine, I've never done it, I haven't done it for a year, don't want to go back and do the acute take. But actually it may well be worth their while doing that and doing the additional training to ensure that they can transition to the new curriculum. And of course, the other thing is they may well have the option to do some internal medicine sessions during their out of program research training or experience. So they may, if they're doing a new PAR in a laboratory based research, they may well have the opportunity to do some general clinics or some sessions on the acute medicine unit in order to upskill themselves in internal medicine. So that's the first thing. I think they really need to think seriously about their options and not just have a knee-jerk reaction, oh, I don't want to do general medicine. The second point is they should be thinking about it now and not waiting till they come back. They need to be having conversations with their educational supervisor, thinking it through about whether they want to transition or not. And if they don't, then they need to be making early contact with their postgraduate dean to find out if it will be permitted for them not to transition. Because I think on the whole, the postgraduate deans are going to take a fairly hard line about it, because for the reasons I've just indicated, it may actually be preferable for people to transfer to the new curriculum. And also the GMC made it very clear that they want people to be on the new curriculum so that they are actually fully trained in an up-to-date fashion rather than on a program that is not the latest the latest program and curriculum.
Thank you, Alistair. Phil, you had your hand up as well.
Pretty much what Alistair said, particularly that point about the postgraduate deans taking quite a hard line. That is what they've indicated. And anyone who doesn't want to take up dual training, I think, has to make a really good case for not doing so.
Okay, thank you. Sue, one question that's been asked is about the OPCAT. Is this likely to be taken up for specialties as well as for internal medicine?
Well, yes, I think it can be a very useful tool, actually. Certainly in my specialty of geriatric medicine, we have a variety of subspecialty clinics, for example, neurovascular clinics in stroke, Parkinson's disease clinics, general clinics, falls and syncope clinics. And also, I think there have been one or two questions earlier about what counts as outpatient clinic work, if you like. There are clinic alternatives as already. So, you know, ambulatory areas, there are lots of different areas that count as clinic experience. And I think an OPCAT is a very good way of commenting specifically on those outpatient capabilities. So I think we should be using it.
Okay, thank you very much. One question that's coming up fairly repeatedly, and Raghu, do you think that the time taken for trainees to take part in e-portfolio activity will be the same, less, or go up compared to what it's been previously?
Okay, let's take it backwards from the end and see. In chronological order, a lot of trainees historically spent a disproportionate amount of time trying to make sure that they had attached every bit of the curriculum with the appropriate number of evidence. And this took a huge amount of what I call wasted effort. It was deliberate and somewhat needless linking just to tick some terrible boxes. And I'm so glad we've got away from that. What we're now having is a much different approach. It takes a lot of effort from the trainees to think about what they need to do, to show that the curricular requirements are met. So the time will be spent differently. Firstly, with the educational supervisor at the initial meetings to try and just work through, what does this SIP mean? How am I going to demonstrate the capability against that SIP across the training period? Having done that, then there's an ongoing process. So every time you grab something, a piece of information, a piece of reflection, keep that in there. And at periodic discussions with the education supervisors, you map that journey so that it doesn't become a burden for the supervisor or for the trainee at the very end. So cumulatively, the amount of time that is spent may not be different. It might be different depending on how much effort has been put in the past. But really, The time we now have for educational supervision is value-added time, because it's an engagement between a trainer and a trainee that unfortunately has been lost hitherto. To an individual ad personam discussion about what the training requirements are, so that when you get to the end, either the RP or the very end, there is no question about spending an odd amount of time just saying that I've done this and that, but the progression through the loops to get to the end becomes a smooth transition. So that would be my summary, is that this is a journey, and you look at the end and work backwards to get there with your supervisors and ask for help early if there's anything that needs to be done.
Thanks, Raghu. Phil, there's a question here about ACCS and whether somebody doing ACCS IM can complete all the capabilities, competencies within 3 years and not necessarily having to do the 4th year. Could you express your opinion about that, please?
So probably no. The way it is set up, you need to come back into internal medicine training and do the equivalent of IM year 2 and then do IM year 3. And you can't really do that in anything under 4 years.
Thank you, Phil. When will the new curricula ARCP decision aids be released? Zoe?
Sorry, they're just being finalised as we speak. So there's been a round of Specialty Advisory Committee meetings. So they'll be published in the next few weeks, and certainly I would say by the end of the month, early May. Most are ready to go sooner than that. And we'll put some Twitter information out on the website and social media.
Okay, thank you. There's a couple of questions that have got quick answers. In the talks and the curriculum, internal medicine appears to be replacing the term general internal medicine. Is this deliberate, and is the CCT going to be internal medicine going forward rather than GIM? Alistair?
The answer is we hope so. I mean, it's designed to be like that. We're allowed to use the term internal medicine all the way through our curricula, but actually to change the name of the specialty, I think it does require just about an act of parliament to do that. The Medical Act lays down all the specialist subjects or specialties that you can be on the specialist register for in the UK, and until we get that sorted out, which we've been trying for at least 3 years, probably, Zoe, probably longer, I think. So hopefully by the time the first person gets their CCT from this, it will be internal medicine. But, you know, and I know I'm guilty of it. I sort of flex between general medicine, general internal medicine, GIM, IM. You know, it's all the same thing. We all know what it means, although we've had some difficulty perhaps defining it this afternoon. But it's all the same thing. And hopefully, as I've said, within the next year or so, we'll have the appropriate amendment to the regulations which will allow us to call the CCT internal medicine, but I say call it internal medicine now. Everybody does, so people know what it means.
Okay, David, is there a particular stage of the year when the ARCP panel, or indeed which year of training, that looks at acceleration in CCT date, or can it be assessed yearly on annual ARCP?
It's got to be assessed yearly. So it's got to be the case that the progress over the course of that year is looked at, and a decision at that RP can then be made. But I think the corollary to that is that it would not happen in the penultimate year. So you wouldn't come to your ST6 year and suddenly be accelerated to have completed ST7. So it would be done at the ST4, ST5 level in particular, but you're not going to have a year chopped off training and suddenly be put out onto the specialty register expecting another year to go. Can I address a couple of things, Mike, just from particularly what Raghu was saying and what Sue was saying? I think of the assessment process as like weaving a rug, and there's a weft and a warp, and the SIPs, if you like, are then held together by the evidence that we put in to hold the whole of the rug together. And it's for the individual trainee and educational supervisor to look at the RP decision aids and the advice that we have and say, well, actually this piece of information will support SIP 1, but it will also support SIP 4. And look at the whole thing in its entirety. It's a holistic approach, not just to training, but recording your training. I know it's a difficult thing because previously we've thought in terms of, I need 6 ACATs, I need 4 CBDs, I need X number of MSFs. And I noticed some of the commentary on the questions coming through are things like, do I need to have an IM MSF report when it's a specialty year MSF that's being done? Use common sense. If you're dual training, put down evidence from both. Have some assessors who are assessing you at the front door, acute unselected take, but also have your specialty assessors down. So I think we've got to stop thinking in silos and thinking in a very linear way about this is my specialty training and this is my general training, and think of it as this is my training. And it also addresses the points that have been raised in the questions of why are we needing to have 20 clinics in specialties other than our own? And there's been maybe some criticism that I've seen from the commentary on screen today of what's the point of that? Why should a trainee do a clinic out with my own specialty? I presume this is from a trainer. Do a clinic out with my own specialty when they're never going to be doing a clinic in that. But it's all about experience. It's about seeing things from a different lens. And I think that's an analogy that Alistair used in his talk earlier, and it crystallises this. It's the ability to see things from a different angle. If you spend the entirety of your career training within specialty, you will only see internal medicine through the prism of that lens. You have to see it from out with. That's all I've really got to say.
Thank you for that. I think that's actually very, very important. We've had over 160 questions, many of them around the same points, but are very individual, and obviously it's very difficult to respond to every single individual circumstance. I would commend to you the pages that Zoe has referred to earlier about transition, and it is important that you engage with the educational supervisor, the TPD in your area, if you're getting any concerns, and at the same time there are avenues by which you can contact JRCPTB so that specific questions could be answered as well. We will take all of these questions and create a response to them where we can, where it's a generic problem. If, however, it is very, very specific, it may be very difficult to provide specific answers. At this point, I'm going to ask if anybody else in the panel has specific comments that they wish to make before we wrap this up. It has been, I believe, a pretty successful webinar, but we will be trying to respond further. Phil.
I think just to emphasize, the relationship between the trainer and the trainee is absolutely paramount to this, and it will not be the same relationship as we've had previously between trainer and trainee, except in special circumstances. We need a good induction each year that sets out the strategy for the training year, and then proper face-to-face, one-on-one time between trainer and trainee, probably at the rate of once per month. The outcome of that meeting is to amend and adapt the training strategy for the year, and it should be evidenced in the portfolio in an additional meeting. If that doesn't happen, then come the end of the year, when the end of year educational supervisor report has to be written, it will be virtually impossible to write a proper, narrated, meaningful report. And this whole system is based on that relationship. Effectively, for 1 year, trainer and trainee become partners in the trainee's progression.
Thank you, Phil. Sue.
Thanks, Mike. I guess I would just like to emphasise that all of us who've been involved in developing these new curricula, whether it's as curriculum leads like myself, whether it's our colleagues at JRCPTB who've been guiding us through it, have been liaising very closely with our trainee representatives. So trainees have been hugely involved in the development of these new curricula too. And I think we all passionately believe that this is a better way of training, and it's a better way of assessing progression through training. So I'd like to sort of leave with a positive note that I think we're heading towards something that is better. I think change is always a challenge, isn't it? But we are all desperately keen to make sure that it works. So if you have worries, speak to people, speak to your educational supervisors, speak to your TPDs, and we will be able to work things out. I think hot on the heels of the ARCP decision aids will also be rough guides, which will take both trainees and trainers through the process of transition as well. So please don't worry, we're on the right pathway, and I'm very positive that we will all work together to make sure that this transition is as smooth as possible for everybody.
Thank you, Sue. I think everybody would echo that. Venkat.
I think I'll echo what Sue said, and we've involved lay reps as well in developing the curriculum apart from the trainee reps. So trainees have been involved, but looking at the questions coming through, some of them have not even looked at their curriculum and asking where specialty SIPs are and what's happening. So they need to look at the JRCPTB website more clearly, and there's more information and more video snippets available. And using the assessment tools and this thing, and I think we can make all of us together make this work well for us and provide a new breed of trainees and trainers. Thank you.
Thank you very much indeed. If there are no other comments that anybody wishes to make, can I thank everybody for taking part? The panel has been excellent in providing very sensible and coherent answers, which have remained pretty brief, which is what we've asked them to do. So that's been really, really helpful. As I say, we will go through the questions that have been posed. We will try and provide written answers, which will go up on the website. I would commend Venkat's recommendation of the PTB website because it does contain a lot of information, and for anybody who is still concerned about what is happening from the beginning of August with the introduction of the new curricula, I think you will be able to find answers on the PTB website. We will continue to respond to people who are making inquiries, and there will be further events that we will advertise to try and get out to people to say this is what's happening. There will be a formal launch of the curricula at the beginning of August, but there will be other events between now and then. Could I thank everybody for your attendance, for your contributions. It has been, I believe, a very successful webinar, and we will look forward to having further contact with individuals to try and allay any alarm and provide reassurance that we do believe this is a better way to go. Thank you very much, everybody.
Thank you.